Everyone. Thank you for taking our time to join the webinar today. As Dharmesh already introduced me, so I'm not going to introduce myself. The topic for today's talk is communication skills in the COVID-19 era. Now, communication between clinicians and their patients has become increasingly important in the age of COVID-19. The coronavirus pandemic has brought many health systems up to and past their medical capacity. In turn, many clinicians are pressed for time and resources, thus making communication with patients more difficult. This presentation provides recommendations and resources aimed to help clinicians communicate effectively while caring for patients with serious illnesses. This is an extraordinary time with unprecedented challenges. We are facing conversations that we never expected or wanted to have, including proactive COVID-19 planning for patients who are already frail with serious illness. And older adults from community are calling our PCPs and saying that under no circumstances I want to be on a breathing machine or go to hospital. And in the hospitals, we have patients who are doing well, laughing with their families, but then they get sick and they go to ICU. And colleagues are having to have these conversations with families with need for interpreters on phone. And this highlights that communication, especially about patient values and preferences, is even more important and challenging during these times with all the visitor restriction policies and virtual technology. So the audience for today's talk are clinicians on, as to how to have conversations with patients, and including patients and families, so they're all prepared to have conversations with their physicians. So at the end of the webinar, I am hoping that you will be able to understand and apply the core principles in communication, engage in conversations with patients and families using COVID-19 communication tools, and with deep dive into conversation guides in outpatient and patient setting with video demonstrations and role play. And also we will know where and how to access additional resources so everyone feels informed, prepared, and supported to engage in conversations and decision making. So our first objective, the core principles in communication, it remains same, whether we are doing it face-to-face or we are doing virtually. We should be using these principles to communicate even with our colleagues, friends, and families on a daily basis. So a recent article in Annals of Internal Medicine was published on communication skills in the age of COVID-19. And it is never too late for clinicians to learn the communication skills. And evidence-based research has shown that positive outcomes in clinician behavior, patient quality of life, and patient trust is based on three core principles. First is dealing with emotions is more important than giving lots of information. Unless we acknowledge the fear, sadness, and anxiety that patients and families experience, they will not absorb the information they need. So you name the emotion, acknowledge and validate their concern. And secondly, deliver in small packages. The information is best delivered when you deliver in small package, then that starts with the headline. When we embed news, especially bad news, in a long technical medical narrative, our patients lose the thread and miss the news. And thirdly, the principle states that patient values should be at the heart of any medical treatment plan. When we elicit values from patients, they feel heard and understood, and they care for towards their medically possible, even if the care is bent toward what is medically possible. The caveat is introduced by the COVID-19 is that a third principle yields to crisis standards of care. Under crisis standards, the ethical foundation shifts from individual values to population-based allocation of resources. So we have some tools, communication tools. Stating phrases like "let's put this together" is very powerful. Active listening includes both verbal and non-verbal. Verbally, you can say, Dr. Mehta also, I think, presented last week. No, eye contact, forward lean, head nods, and then reflective listening. You listen to the patient, understand, and then provide a verbal feedback with underlying meaning or emotion confirming the understanding. And empathy and paraphrasing and silence, very powerful. And always remember, ask, tell, ask. Before you say anything, before you tell, always ask. So let's move on to our second objective. And we'll do a deep dive into outpatient care, the conversation guide for COVID-19, developed by Ariani Labs, a joint center for health systems at Brigham Hospital and Harvard School of Public Health in collaboration with Dana-Farber Cancer Institute. And some of the slides are adapted from the video presentation at the Ariani Labs website. So this is, I will walk you through the guide very briefly. The structure is set up, assess, share, explore, and close. And this framework can actually be modified for conversation with any patient, not just COVID. And you can use these phrases mentioned in this guide. So what is the COVID high-risk conversation guide for outpatient care? What it really does is equips clinicians to proactively outreach the high-risk patients in the community who may be at high risk of complications and serious critical illness from COVID due to their underlying condition. It emphasizes prevention, that is protection from getting the infection in first place, and preparation in case they do. And it focuses on what matters most and the surrogate decision making. So I'm going to play a conversation guide video before I actually go through the guide.
What matters most to them in the event that they contract COVID-19 and become very sick. In this short video, we demonstrate use of the outpatient conversation guide with primary care physician Dr. Justin Sanders in a simulated telehealth visit as part of routine ambulatory care. We also briefly describe the toolkit and other resources available. Mr. Garcia is a 72-year-old retired bus driver who lives at home with his wife and 19-year-old granddaughter. He has chronic obstructive pulmonary disease and type 2 diabetes. He is a current smoker.
Mr. Garcia, it's really good to see you. I'm really glad that we had a chance to catch up today for this visit and talk about your medication, see how you're doing. I know it's strange on this, in this new way, but it's great to see you.
Yeah, and it works. It's good to know that we have something like this now.
Turns out it works, yeah. I would love if we could spend just a few more minutes together. This is a difficult and scary time with the coronavirus, as we're all feeling. I'm hoping we can talk about what's important to you so that we can provide you with the best care possible in this time. Is that okay?
Sure, yeah.
Okay. What do you understand about how the coronavirus could affect your health?
Well, I understand that in people my age and older, it can be pretty severe. So that's the thing that I hear the most.
Okay. And what are you currently doing to protect yourself from getting the virus?
Only going up when necessary.
Okay.
Going to the supermarket, pharmacy if I need to pick something up. And we'll go out around the neighborhood here if it's a sunny day, but we'll keep our distance from people if we bump into anybody when we see them on the street.
Good. It sounds like you're taking the social distancing really seriously. I'm really glad of that. How about your granddaughter? Is that right?
The parents marathon.
Thank you, Daddy.
I think she's at the point where she understands how serious this is. She's really getting it.
Good. I'm glad to hear that. May I share with you my understanding of how the coronavirus will affect your health?
Sure.
Okay. Most people who get the coronavirus get better on their own. Okay. However, people who are older or have health problems like yours can get very sick and may not survive. The treatments that we use to try to help people live, like breathing machines, do not work and if they do work, recovery from the illness is uncertain.
Are you saying this applies to me?
Sounds like it's kind of surprising to hear that it might.
Yeah, it is surprising.
Well, so you got a chance to see a very short preview. The video itself is under 10 minutes. So you see it mentions the difficulty and scary times with coronavirus as an indicator of shared experience. And then in the assess section, the second section, it asks about the understanding of patients' understanding of illness. And they added a specific open-ended question about protection. Because they felt that the biggest priorities is to ensure that patients are protecting themselves and to provide an opportunity to counsel patients, which might happen during this conversation or maybe the next visit, and then asking permission to share physician's understanding. Now, in the third section, the shared section, there were when they were developing this guide, they were thinking about, few conversations as to how much information to share. That was the first, they had to balance that. And they worked on sharing not too much information so that they don't overwhelm patients, and not too little so that they don't have enough information and understanding and think about what would be important for them. Second was just the uncertainty of the virus. Many people recover, some don't, especially those with underlying conditions. And then lastly, but just thinking about how to titrate this information to patients' anxiety. And then you heard them, in this share, he said, most people who get the virus get better. However, those who are older, they may not get better. So they shared, as an open-ended statement. This was to balance as to how much information to share with, of course, pause and responding to emotions. So this was all framed in hope, prepare model. That is, hope for the best and prepare for the worst. We really hope you don't get the virus, but it's important to prepare in case you do. And given your medical knowledge, medical condition, I would like to think together about what would be important if you do become sick and couldn't speak for yourself, which is really the goal of the rest of the conversation. And then explore as to what's important for you, anything they're worried about, what abilities are very important for them. And then, in explore section, the latter half, they also gave the opportunity for people to bring into this conversation some of their preferences. If we think they may not help or may cause suffering, some people make decisions to avoid treatments like breathing machine or CPR if they get very sick. So people actually may be in very different places about whether they have thought about the kind of treatments they may or may not want if they get very sick. So they decided to go with very soft language by just asking people, have you thought about medical treatments you may or may not want? To give people a chance to express their preferences and also to say, no, I have not given it much thought. And then maintaining a question about family involvement and family knowledge of patients' wishes. And then again, when making this in the closed section, there were again some tensions during this recommendation as to how specific they should be. And the second was the variety of next steps, that it's really important, I think, to think about the fact that, not all recommendations will be the same, and how can we handle that? So the choices that I made was that by naming that it's hard to talk about, you are acknowledging and validating, and it's a warning shot. And then reflecting back by saying what clinician heard patients say. So what they were thinking here was that every patient, it really is important to have a sense of who their decision maker is, and then encourage and recommend that patients have the conversations with them, and that there's an opportunity for many of the resources which are present to support them. And lastly, in the closed section, they added an open-ended statement recommendation which allowed clinicians to share their recommendations based on their clinical knowledge. And then closing that this is an uncertain time. As always, we will do everything we can, reconfirming the commitment to patient care. So there are some brief telehealth communication tips which are adapted from Mass General and Dana-Farber Cancer Institute. For the outpatient, when you open the conversation about the environment and privacy, patients may or may not want family members involved when discussing their priorities. And then there are techniques for verbal or nonverbal, for responding to emotions, verbal and nonverbal, which we discussed. And normalizing and validating both the positive and negative emotions. For example, by saying it makes perfect sense that it feels difficult to live with this uncertainty. And then silence, very powerful. People feel uncomfortable, but pausing with silence after sharing hard news allows time for patients to process their emotions. During silence, continue to look into the camera, head nods, and maintain the connections. Patient will break the silence when they're ready by reinitiating the eye contact or talking again. And you can put your hand at your heart to as a gesture of empathy. And then reflection and curiosity we already talked about. And then attending to chores during the visit. Home environment may change during visits. Kids and grandkids, if they enter, patients may not feel comfortable. And then secondly, pay attention to signs that patient is struggling with the discussion. If they're breaking the eye contact or they're shifting, you can say, I know this is hard to talk about, and I think we covered a lot. Thank you so much for sharing. What are your thoughts about shifting gears and talking about something else? And then in the end, by ending while ending the session, you begin to wind down the conversation when it's more interpreted. You can say, we are committed to caring for you and we'll do everything we can. And then you can even, consider naming the short amount of time. You can say, we only have 10 minutes. Is there anything important you want to discuss? So I'm going to do a brief role play of couple scenarios. And I had my son volunteer to play a patient, Mr. R, and I will be a physician. And this is adapted from the Vital Talk. So when you're triaging a patient, when you're deciding where a patient should go, what can people say?
Why shouldn't I just go to the hospital?
Well, our primary concern is your safety. We are trying to organize how people come in. Please fill out the questions online and you can speed up the process for yourself and someone else.
Why are you trying to keep me outside of the hospital?
Well, I imagine you're worried and want the best possible care. Right now, the hospital has become a very, very dangerous place, unless you really, really need it. The safest thing you can do is stay home. But the second scenario is when you're trying to admit somebody when your patient needs the hospital or the ICU.
Is my grandfather going to make it?
I know this must be scary because he's 90 and dealing with other illnesses. It is quite possible he won't make it out of the hospital. It's too soon to say for certain.
How can you not let anyone visit? I'm on a own here.
I can only imagine how hard it is not to have visitors. Right now, they will be more in danger if they come here. You can use the phone, although I know it's not the same. I wish I could let you visit because I know it's important. So sadly, it is not possible right now. And then, when you're notifying somebody or telling someone,
yes, I'm his daughter. I live 5 hours away.
I have serious news. Are you somewhere we can talk?
What's going on? Has something happened?
I'm calling about your dad. He died a short while ago. And the cause was COVID-19. I am so sorry for your loss.
I knew this was coming, but I didn't expect it so soon.
I can only imagine how shocking this must be. So this was just a brief role play of common scenarios which you may encounter. And now I'm going to walk through this inpatient guide, but I'm not going to go through it the same degree as we talked about for outpatient. I'm just going to focus on few key areas for the inpatient guide. So this is again from Ariani Labs Joint Center at Brigham Hospital and Howard in collaboration with Dana-Farber. And you can look at the video online. The link is attached. And you can see it's again a one-page guide, and it's very similar to the outpatient guide. The goal is to equip patients to ideally, to equip clinicians to have conversations with COVID patients in the hospital, ideally early on, because these patients can get sick very quickly. Emphasize the patient values and preferences, and inform decision-making about life-sustaining treatments. Once again, this is not a guide for crisis standards. And during the shared section, during shared and closed section are the ones which I'm going to discuss. So while updating the shared section, one of the tensions was, uncertainty and how quickly patients can get sick. And then there were different levels of risk as well. Young patients who get sick, and others are the elderly patients with underlying conditions who get sick very quickly. So we all have different kinds of worries about them. And then in this share section, they created options. They started by sharing that many people will recover from this infection. We will do everything we can to help you recover. As you've probably heard, some people get so sick that they do not survive. Then patients who might have normal risk, we wanted to normalize that everyone should have this conversation. So because there is some uncertainty about how this illness affects people, we are asking everyone to share that what would be important if they become very sick and couldn't speak for themselves. And then if the patient is high risk, you say, because of your whatever is the high-risk condition, if you get really sick, I worry that the treatments that we can use to try to help people get better, like breathing machine or CPR, are not likely to work or get you back to the quality of life you had before. Followed by the pause, and then validating, that this must be hard, acknowledging to hear. So then in the last section, the closed section, again, there were some tensions because of the mismatch between patient preferences and medical situations, because the recommendations may be different, and the patient may not be certain about what their preferences are. So, and in the end, really saying it's hard, again, maintaining that open-ended question that it's hard to say, maintaining that reflection that I heard you say. Given that you told me what we know about your condition, we would recommend two choices. So choice A and choice B is, you can use these scripts when you're talking to patients that use intensive care if necessary, including CPR or breathing machines. So there you can say if something changes to make us worry that these treatments are not likely to work, we will tell you or your decision maker. Is that okay? When you're asking them this question, it may make them feel that they can make a decision in that moment. And in the situation B, where you provide treatments only if we think are helpful, this means that we will not do CPR or breathing machines, but will provide all other available treatments to help you recover and be comfortable. Again, asking them, is that okay? And then closing them that we can revisit this anytime. And then lastly, the resources for patients and physicians. So for public, the resources were developed in collaboration with the Ariani Lab and the Conversation Project and Institute for Healthcare. So first recommendation, there are three important things which you can do at this time. First, pick someone to be your healthcare decision maker. Choose someone you can trust to make decisions for you if you become sick, And then secondly, talk about what matters to you most. Talk to those who matter to you. And then thirdly, think about what you would want if you become seriously ill with COVID. Think about what worries you most about becoming seriously ill, and what's important to you, and what kind of treatments you may want. And there's a very powerful video for the caregivers by Anthony Bass and Vital Talk. And this is an excellent resource. One of the source of communication tools is the Vital Talk, which has created a primer designed to provide practical advice. And this is supported by John Hartford Foundation as part of our Building Public Engagement and Access to Palliative Care. And this is a COVID-ready communication playbook. It provides a compilation of the scripts and tips for clinicians. I'm just going to show you this exactly. You can download it on your phone. The app looks like this Vital Talk. And if you click it, it's exactly like this. And you can go over each, screening questions. It'll give you the exact script which you can use to talk, to have conversations. And then there are other, in Annals of Internal Medicine and this Vital Talk, they created the talking maps for proactive outreach for COVID patients at home, the acronym COMMER. And these are the additional resources. If you only need to go one resource, this CAPC, Center to Advanced Palliative Care, is where you go, and you will find all these resources there. So take-home messages are, you apply the core principles in communication, and we should use these principles even when we are talking to our friends, colleagues, patients, anybody. Use conversation guides and talking maps which have been developed for COVID, and use the resources for public and physicians both. As Sir William Osler said, the good physician treats the disease. The great physician treats the patient who has the disease. Thank you very much, and we will take questions in the end.
Thank you, Dr. Gupta. Very nice talk. And now we will change into a different tone. And the next presenter is Dr. Dalbir Sandhu. And Dr. Dalbir Sandhu is going to talk about the decoding the gut feeling in COVID-19. Dr. Sandhu is a director of endoscopy, Division of Gastroenterology and Hepatology, Cleveland Clinic, Akron General Medical Center. And he has an extensive research experiences in the endoscopy and especially the advanced endoscopy. Here we welcome Dr. Dalbir Sandhu. Dr. Sandhu.
Okay, can you hear me now?
Yes, very well.
Okay, thank you, Rupesh, for that introduction. And thank you, APNO team, for giving this opportunity to talk on gastrointestinal system and COVID-19. As you can see, the topic of my webinar is decoding the gut feeling in COVID-19. There's some pun intended there, as we are still trying to decode the virus, the management, the treatment, and of course, trying to develop a vaccine for it. So, without further ado, I'll get to my presentation. I'll give you a quick overview about the COVID-19 and the coronavirus, which I'm guessing most of you already know, but it's an infectious disease caused by the recently found virus known as the SARS-CoV-2 or the coronavirus. There are coronavirus is known to cause a disease in humans. 80% of cases are mild to moderate in severity and spread by droplets. And on an average, 1 person spreads the virus to 2 to 3%. The incubation period is anywhere from 1 to 14 days with an average of about 5 days. A person can be infective from 12 hours prior to onset of symptoms to about 5 to 6 days. And symptomatic individuals are more infectious. So I guess no presentation on COVID-19 is complete without this figure from Johns Hopkins. This is the red dot map of which all of us dread to see these days. As you can see, we almost have 3.5 million confirmed cases of COVID-19 all throughout the world, with about 1/3 of those cases in the United States. And we have about 250,000 deaths from this deadly virus already. A quick overview of the timeline. Back in December 2019 is when China reported multiple cases of pneumonia to WHO. During the week of January 7th, 2020 is when the virus was isolated, the genome was sequenced. It was named as the 2019 novel coronavirus, and China reported its first death. January 2020, a lot of twos and zeros in that date, and which I don't think any of us can forget, is when first COVID-19 case in the United States was reported. The first death in the United States occurred on February 29, 2020, and WHO declared it to be a pandemic on March 11, 2020. So most of us think that the symptoms of COVID-19 is predominantly respiratory in nature, with the high fever, headache, a dry cough, which is constant without expelling any mucus, and dyspnea, which is like shortness of breath. Many of you may not know this, that the first patient in the US actually presented with nausea, vomiting, which progressed to respiratory symptoms, and then abdominal discomfort and diarrhea. So that brings to my objectives of the talk today. I'll be talking about gastrointestinal symptoms in COVID-19. We'll see if there's any fecal oral transmission of virus. Then a little bit about COVID-19 and pre-existing liver disease and pre-existing IBD, like Crohn's disease or ulcerative colitis. And lastly, endoscopy and COVID-19. So this is a figure which has been presented before also in the webinar. As you can see, the SARS-CoV-2, it utilizes the ACE2 receptor for its entry. And again, it's very predominant in the pulmonary system, but not many people know that the GI tract is also full of these ACE2 receptor, and it has been postulated that the virus replicates pretty actively in the GI tract. Going to the gastrointestinal symptoms, diarrhea, anorexia, vomiting, and not necessarily respiratory symptoms may be present. There were a couple of studies published in gastroenterology. This figure a little hazy, but still, I guess most of you can see that about 45% patients presented with both digestive and respiratory symptoms, and about 42% patients had only respiratory symptoms. Of the about 50% patients with digestive symptoms, about 84% reported anorexia, which is the loss of appetite, and about 30% reported diarrhea. Now, GI symptoms are not new to SARS-CoV. When back in 2002 and 2003, we had the SARS-CoV-1 infection, GI symptoms were quite commonly present at that time also. And active viral replication has already been shown in the intestinal tract, which is confirmed by electron microscopy and viral culture. Some of the other symptoms, anosmia, which is loss of smell, or dysgeusia, which is loss of taste. And many studies have now shown that these could also be the predominant symptoms of COVID-19. One of the studies from Italy showed that this could be present in almost about 20%, although Chinese studies show a little less, about 5 to 6% of patients presenting with these symptoms. Going back to diarrhea, diarrhea is generally mild. It is non-dehydrating, up to 3 times a day. Both adults and pediatric patients can present with diarrhea, although vomiting is more common in children. Now, there has been a case report published in the Red Journal, which I'll show in the next slide, which presented with the bloody diarrhea and on colonoscopy, they found to be hemorrhagic colitis. Voluminous diarrhea is very less common. There has been a case report of a 41-year-old woman from Michigan who presented with the large volume diarrhea and electrolyte abnormalities, and unfortunately, she succumbed to the virus. Now, these are pictures of colonoscopy in that patient I was talking about earlier. This is a case report published in a Red Journal back in April 2020. A 71-year-old lady who had a recent trip to Egypt on the Nile River cruise, and she presented with bloody diarrhea, and eventually she was found to be COVID positive on her nasopharyngeal swab. Now, another study, I think this was one of the initial studies published on reporting on GI symptoms in COVID-19. This was from 3 centers in China, about 200 patients, about 50% had GI symptoms. If you exclude loss of appetite, about 20% had GI symptoms. Now, lack of appetite is the most predominant GI symptoms noted in patients with COVID-19, about 80%. Next is diarrhea, as you can see, about 35%. Vomiting, a little less common, 4%, and abdominal pain is probably the least common GI symptom seen in about 2% of the patients. As you can imagine, since most of the reports initially mentioned that the symptoms are predominantly respiratory, these patients took longer to present to their hospital or to their physicians if they had GI symptoms. In this study, they did not show any difference in the length of stay or ICU admission or mortality. Now, it's interesting, the virus has been there for only 4 months now, and we already have close to 2,000 studies on COVID-19. We have several meta-analyses published on GI and COVID-19. This was published very recently, a couple of weeks ago, in Gastroenterology. They had 60 studies, about 4,000 patients from 6 different countries. In this meta-analysis, they showed that the GI symptoms were present in about 18%. Again, anorexia was the most common, about 27%, diarrhea about 12%, nausea, vomiting about 10%, and abdominal pain about 10%. And the meta-analysis also reported that severe disease was more common in patients who had GI symptoms compared to who did not, 17% compared to about 12%. So as you can see, the numbers are a little all over the place, but the main point is that these patients can have GI symptoms as their presenting feature, and anorexia and diarrhea are probably the most common. And the GI societies have actually been asking the CDC to include this as one of the screening questionnaire for screening for patients with COVID-19. Now, switching gears here a little bit, talking about whether the virus can be transmitted by fecal oral method or not. But before I talk about that, I'll show you this slide, and I'm sure most of you have already seen this or know about this. This was published in NEJM, and they showed that the aerosols are viable for about 3 hours, and the virus was viable on copper for about 4 hours, on cardboard for about 24 hours, and plastic and stainless steel can have a virus detected even up to 72 hours. Now, this was published in Gastroenterology, study again from China, and they looked at about 73 patients, found that half of those patients had positive stool RNA, and about 23% remained positive in stool even after they had negative respiratory samples. And they showed that the SARS-CoV-2 RNA could be detected in the gastric, duodenal, and rectal epithelial cells because all these organs or parts of the GI tract have abundant ACE2 receptor, which was seen on immunofluorescence. As you can see, esophagus has a different lining. It has more of a squamous lining compared to the columnar lining of rest of the GI tract. And esophagus did not have much ACE2 receptor, and subsequently also did not have high levels of SARS-CoV-2 RNA. They mentioned that it could be implicated for stool testing instead of nasal swabs, which most of us know can be really painful. Now, another study published in Lancet by Wu, and they found that about 55% of patients had virus in the stool. And as you can see over here, I don't think my pointer is working, but these respiratory samples remained positive for virus for about 16 days, compared to almost 28 days in the stool, about 11 days longer. And one patient actually had a positive stool sample for 47 days. So there have been significant concerns about the virus replication in the GI tract. Since then, several studies have shown that the virus remains active in the stool samples, could be for a long duration, and hygiene has been recommended, including, of course, the hand hygiene, but also like closing the toilet lid after flushing, or sorry, before flushing, and not using the same toilet for a few several minutes before somebody else has used that. Now, a little bit about COVID-19 and liver. Just like the GI tract, ACE2 receptor is also present in liver and biliary epithelial cells. The virus has been postulated that it can have a direct virus-induced effect or an immune inflammatory response to the virus, or drug-induced liver injury, because many of these patients are getting different kinds of medications. A role of ischemia and congestion has also been reported, although no evidence that pre-existing liver disease increases susceptibility to COVID-19. These are the common lab abnormalities you will see in patients who have COVID-19, predominantly, of course, for the people dealing with the people managing patients on this webinar. But ALT, AST elevation is seen in up to 50% of patients. Alkaline phosphatase is less commonly seen, about 2%. The total bilirubin could be elevated in about 10% of patients. The liver injury, or the pattern of liver injury, is predominantly hepatocellular, with increase in AST and ALT. And the liver injury is mild and transient, although there was one case report of a 59-year-old lady who presented as acute hepatitis as for COVID-19 presentation. For these patients specifically, it has been mentioned that they should limit the acetaminophen intake to less than 2 grams per day. This is one of the best resources if you are managing patients with COVID-19 and liver. There's a lot of information, so it will be there. A little bit about COVID-19 and inflammatory bowel disease. As you know, many of our patients who have IBD are on immunosuppression, predominantly thiopurines, and prior studies have shown that thiopurines like azathioprine or 6-mercaptopurine can increase viral infections. Many of these patients are also on anti-TNF, and this, as you can see on the top, I pasted a study, not a study actually, an article in Lancet, which requested that more anti-tumor necrosis factor should be tried for COVID-19, because it has been shown that TNF alpha is involved in SARS-CoV pathogenesis, and since SARS-CoV-2 uses the same host cell receptor ACE2 as SARS-CoV-1, So there could be some implication. There was a small study using Humira or adalimumab in China, although more recently the studies are not in favor of anti-TNF. Steroids, definitely it has been shown that it leads to worse outcomes. We know that it led to worse outcomes in influenza and even in MERS, and now studies have shown that high-dose steroids can have worse outcomes even in COVID-19. Now, most of our information on immunosuppression and COVID-19 was predominantly from a solid organ transplant and cancer patients, but now we have a registry, which I will show you later, and we have more information on COVID-19 and IBD patients. There is a case, again, published in Gut, I think back in February 2020. This was from Italy, an 80-year-old lady who had controlled left-sided UC, ulcerative colitis, maintained on mesalamine for 3 years, and she presented with the bloody diarrhea and fever of 7 days. That's her sigmoid colon, as you can see, like real bad inflammation. Initially, it was thought to be UC exacerbation, improved with steroids, but on 4th day, she developed fever and cough, and she had SARS-CoV-2 positive. Her chest X-ray and CT chest showed bilateral pneumonia consistent with the COVID-19. She was started on lopinavir, ritonavir, and hydroxychloroquine. Her IV steroids were quickly stopped, and unfortunately, she died on the 14th day of her admission. Now, this was the database that I was telling you about before. This is a secure IBD. This is an international registry of pediatric and adult IBD patients. I think it started by, I think, Duke University. As of April 30, which is most recent, there are about 877 patients reported who have COVID-19 and IBD. About 285 are from the United States. If you see down there, about 67% are being managed as outpatient, 32% hospitalized, 6% are in ICU, and about 3% death have been reported in patients who had IBD and COVID-19. This is an international organization for the study of inflammatory bowel disease, a group of experts who have been giving recommendations about how to manage IBD. It's a very, very good source if you have IBD or if you manage patients with the IBD. And they reported that the risk of COVID-19 in IBD patients is same as general population. This is a table I made. If if you're managing patients with IBD, and as you can see, 5-ASA or mesalamine is the safest medication currently, which should be continued. But prednisone, and which is marked in red, especially more than 20 milligrams per day, has been reported to increase susceptibility to SARS-CoV-2 and also have worse outcomes in patients who have SARS-CoV-2 or who are COVID-19 positive. And again, I do not recommend to stop any of these medications on your own, but this is something it should be discussed with your GI doctor. Most of these medication, as you can see, should be continued if you are on these medications and if you are like trying to prevent getting the infection. But if somebody is positive either for the virus or for COVID-19, there are different recommendations, and especially azathioprine, methotrexate, and tofacitinib should be discontinued in these patients. Now, going to endoscopy and COVID-19, as of March 19, CMS came out with these guidelines, which was followed by states all over the United States. They mentioned that all the elective procedures should be delayed. And as you can see, the first column is elective procedures like screening colonoscopies or evaluation of non-urgent symptoms. But anyone who has upper and lower GI bleeding or dysphagia. And these are, I've mentioned in the right side of this table. These are urgent procedures, and they should be performed. Now, as we relax our like all the societies are now relaxing their instructions about managing COVID-19, and hopefully in the next week or two, we will restart the elective procedure. You want to know what happens in the endoscopy room. These are some of the things: scope cleaning and reprocessing. The societies recommend that the standard technique should be followed, but minimizing the staff involved in the scope handling, and experienced reprocessing technicians should be used. Room cleaning, both pre and post COVID-19, should be very, very meticulous, and the time can be reduced if the room is a negative pressure room. Now, the endoscopy storage is always done in a secure storage cabinet, and that's what's recommended by all the societies. Again, this is as we safely resume the endoscopy. This is a roadmap regarding PPE, because there have been a lot of concerns about shortage of PPE. If a patient is getting a procedure in the ASC and they are in the low prevalence area, or they had a negative rapid test or negative symptom screen, just using the standard precautions, which we always do, like a surgical mask, face shields, gloves and gowns. But if they have high, if they are from a high or low prevalence area, but positive rapid test or positive symptom screen, ideally these patients should not be getting their endoscopy at the ASC, but should be done in the hospital setting with all proper PPE like N95. Now, most of you already know this. The virus spreads by droplets. The wet droplets, they fall due to gravity, but they also evaporate very quickly into aerosols. And aerosols is not the transmission of the virus via aerosols is not prevented by the face mask. This is when one should be using N95 respirators. This is a little bit about 2 slides about how to don and doff the PPE. As you can see, donning is a little easier. First step is to put on the hairnet, then clean the hands, put on the gown, mask, goggles, and last is to put on the gloves. Now, doffing is much more cumbersome, but also needed to prevent transmission, especially if you have done endoscopy on a COVID-19 patient. As you can see, there are several steps, including the hand hygiene, including when you have the gloves, it's recommended that you start the hand hygiene right then. And the first thing is to remove the gown after putting on new gloves. Quickly, most of us already know this, how to prevent the transmission of the virus by wearing masks, staying at home, washing your hands with the alcohol-based disinfectants, and covering when you sneeze. Now, this is something I want to bring to everybody's attention. These are uncharted waters. You will see a lot of studies. Most of these journals, including high-ranked journals with high impact factor like NEJM, have been publishing anything and related to COVID-19. I can understand the editors have to bring this information out in the public as quickly as possible, and the review process may not be as stringent as one would expect for these journals. So any study that you see, don't just go by that, and I would say use your own scrutiny to analyze that study. I would end my presentation with this paper from Nature published last year with a ray of hope. Again, this is not my domain, but I'm and most of us are hoping that we will have a vaccine soon for this virus. Over 90 vaccines are currently being developed all throughout the world, and at least 6 groups have already started injecting formulations into volunteers in safety trials. So thank you for your listening, and I and Mona will be happy to take any questions.
Thank you, Dr. Sandhu. And first of all, I want to thank both you and Dr. Gupta for giving your time for such an excellent presentation. A lot of information about the GI involvement. And now I will open the session for the questions. And anybody who wants to ask question, please unmute yourself and then direct question either to Dr. Sandhu or to Dr. Gupta.
I have a question. Another round of great presentations by Dr. Gupta and Dr. Sandhu. My question is for Dr. Sandhu. Since the virus stays in the body with the longer duration, since they have GI symptoms, do we have a different quarantine measures for patients who are presenting with GI symptoms?
That's actually a very, very excellent question. And currently there are no, at least to my knowledge, there are no reported cases of transmission via fecal-oral route. And the quarantine is the same as recommended, but the hand hygiene and the toilet etiquettes that I was mentioning before is what is recommended for these patients. But there are no special or no other quarantine recommendations like longer if you presented with the GI symptoms.
Thank you.
Any more questions?
Yeah, hello, this is Dr. Kumar for Dr. Gupta. Excellent presentation done in a very excellent manner. I definitely like the optics, and I think the real star was your son. However, I would like to ask you that it is pretty complicated for doctors to go ahead and learn. It's a new learning curve for us. Trying to learn how to manage and assess these patients, online with a video chat. And is there any HIPAA issues with letting the patient know? I know you talked about it a while, but what else could we do to make this better for our patients so that they are, they feel good when we talk to them about, sometimes about specific important personal questions?
So, I'm sorry, I'm trying to understand the question. So if the question is mainly about HIPAA regulations, when we are doing
patient expressing themselves in front of this camera with sometimes their family coming in and out,
Right. Yes. So that's what I discussed, we have to treat it, even if with telehealth, as if you're talking to patients face to face. If you do see somebody, some family member coming in, you may have to stop and ask patient if that's okay. So you have to be mindful of, or you may, stop your conversation and make sure if the patient feels comfortable with them being around him, then him or her, they will be okay. Otherwise, give them some time to tell, the family members not to be there, or you give them a cue and ask them if they want to move to a private spot. So it has to be as if you're facing the patient in the room, and you have to respect their privacy. In that room, stop for a minute and ask them if the other people are okay, or move to a private room. And that's an excellent point, an excellent question.
Yeah, thank you.
Any more questions? So Mona, I have a question for you. First of all, a nice presentation to explain how to communicate. I think my challenge here is to communicate with the patients who are really sick and terminal and on the support of lungs and kidney. And most of the time the mortality is pretty high because you're seeing them at a tail end with a lot of complexity. How do you deal with the family at that point of time where you have resources of ECMO very limited and they are on ECMO for a long time, and it's a time for them to kind of say, hey, we have to withdraw these supports because more patients are coming. In a single hospital, you cannot have people running like 6 ECMO. We have just 4 or 5. So how do you deal with them with the resource allocation when you know the mortality and morbidity is very high, and then you have to supply to the new patient coming in? And that's a very challenging talk to do with the family.
And I agree, Rupesh, that is very challenging. And that's why I said, we do respect patients' values and preferences. So that, but that caveat, it used to the crisis standards. So the ethical standards, they shift from individual values to population-based resource allocation. So, if we feel, thankfully, I think we are not in that situation here. So that is one, at that point, you have to take into account your own hospital policies. But to answer this about when you're at the tail end and how do you deal with them, I think that's why it's good to talk about patient values and preferences or have these goals of care conversations a little bit early on, not in a crisis situation. And even if you do have to, then what the best way to frame that is, asking the family members as to imagine if your loved one is sitting in the room with us in this chair, and what would he or she speak? What would they say when they're looking? Imagine their soul is out, sitting in this room and looking at the whole situation. What would they have wanted? The family is only their voice. They are not making the decision. Tell them you are not making a decision for them. You are just their voice based on the type of person that you knew your loved one the best. What would they have wanted if they were able to speak for themselves? Because you know them the best. If they were sitting in this room listening to this conversation, if their soul is outside, what would they have said? I think that is the best way to frame, because you don't want families to feel guilty. So that's why just taking that guilt away from them, that they are not making that decision. The patient is making the decision, patient's body is making that decision, and they are just the voice for the loved one. So that has been very helpful in the conversations. When you tell them, tell me more about your loved one. What sort of a person were they? What did they enjoy doing? What was it? What brought meaning to their life? I think they would have wanted something like this. And then again, reflecting back, as I also said in the closing, what I hear you say based on how your mom or dad or your loved one was, they would not have wanted to be bedridden or not being able to communicate, not being able to know surroundings. So no, then they say, oh no, they would not have never wanted. So that's why getting starting with as to where the patient's baseline was is very helpful.
Thank you, Mona. Any other questions?
Just one more, if I may, Dr. Kumar again.
Please.
We usually take a consent. We're supposed to consent before we start the session online, with the video chat. Is it supposed to be just said by the physician that the consent was taken? Or is it more than that, like we take a consent sometimes for a procedure when we have two witnesses who signed for this consent?
Is that question directed to me, I presume?
Yes.
I don't, we have not been taking consents as such. Of course, we consent from the patient. We talk to the patient, make sure the patient is okay. Actually, if the patient is able to converse, we have the conversation with the patient there. So they're part of the family meeting and involve them in those conversations. And if the patients cannot participate in the conversations, then it's like any other conversation which you have with the family members face to face. If the patient is unconscious or they're intubated, they don't have decision-making capacity, it's like having conversations with family members in that situation, like you will have face to face. But try to involve the patient if they can.
So answering Dr. Kumar's question, this came up with us too with the telehealth. So when you arrange telehealth, your secretary or your nurse is calling them, definitely you have to send them an email. I use DoxyMe, which is a very good way of doing. When you send them an email, lay down certain rules that this is because of the COVID, you're doing the face-to-face thing. This is DoxyMe, is a secure website. I will request you to introduce a person who will be sitting with you and give me consent that he or she will be able to listen to your conversation with me. Number 4, please identify any other person in the room. So I can email it to you, and we send them to the patients before, but they have to give us a verbal consent for using their pictures, and we have a very good smartphone too. I would like to share that, and this has come up with us big time, like whether we have a consent, whether they are agreeable, but identifying who is in the room, what is their relationship. Even when you start, you say, oh, this is your wife, so and so. Are you okay for me to discuss your health and your medical records or your labs with him? So we still identify with them. And I also say, during this conversation, when anybody comes in the room, please make sure you tell me. I will stop the conversation. Or if he comes in, please introduce and consent, then I will move on. Those rules needs to be very clearly identified. Practice to practice.
Thank you, Rupesh. That was an excellent explanation. So just basically, Vikram, just think about it as if you're doing a face-to-face conversation.
Yes.
Same rules apply. It doesn't matter whether it's telehealth or you have to think as everything you would do in a family meeting when you're face-to-face. Everything applies.
Thank you.
With that, I think with the time constraint, I think we'll close the session. Again, on the behalf of EPNO and the Executive Committee, I want to thank Dr. Dalbir Sandhu for excellent presentation, and Dr. Mona Gupta, she's a part of our Executive Committee. Thank you for giving the informative session. Just to inform you, the last webinar will end on this coming weekend. That will be weekend of 8th and 9th. After that, we'll hold on the webinar, and then we'll decide how to move further. With that, I want to thank you all for supporting this vision of education and everything, and people are really enjoying. And my special thanks to Dr. Neil Mehta and Dr. Vikram Kumar. They are our CME chairs and bringing this kind of education to all the EPNO members. You guys have a great weekend. I'll see you around and stay safe.
Thank you, Rupesh.